Hi, everybody. So my topic was approach to chronic kidney disease, which is 1/4 of my fellowship. So we'll see what we can do in the next hour or so. Um, let- so I'm going to just talk about briefly about the CKD burden to society and the individual patient, challenges from primary care or medicine perspective in dealing with CKD, the evolving definition of CKD, when to refer to nephrology, and what are the options or what can we do to delay the progression of CKD. So as you probably know, 1 in 7 people walking around you suffer from chronic kidney disease. That's 15% of US adults and about 37 million people in the country. The prevalence of CKD has been increasing over the years, as you would expect, with the epidemic of diabetes, metabolic syndrome, obesity. So yes, we do see increasing prevalence of CKD as well over the years. The next few slides, the data is from the USRDS, or the US Renal Database, that is maintained by CMS. And it's mostly based on Medicare, beneficiaries. So it's older people that are mostly included in in this database. But regardless, so when we look at CKD, from an individual perspective, from a patient perspective, they have almost 1/3 or 3 times higher chance of higher likelihood of hospitalization compared to a person without CKD. And that's quite significant. When it comes to mortality, again, 3 times higher mortality than anyone without CKD. And this is adjusted for, other comorbidities, age, sex, and race as well. When we look from a society perspective, we are spending about $49 billion every year for management of CKD. And mostly it's, the Medicare expenditure goes towards diabetes, heart disease, and CKD. Those are the 3 biggest expenses. When we look at individual person, we spend about, for CKD stage 4 or 5, we are spending about $30,000 per year, per person per year. That's quite a bit. Any guesses how much does it cost for somebody to undergo dialysis per year? Any guesses towards that?
What do you
So
think?
what's that?
I was asking what if someone has any
Yeah,
idea.
if someone has any thoughts, I can't read the chats.
3,000.
They're saying 85,000, and Betty, what did you say?
I said 250, but I also have
Ooh.
no idea.
Okay, so in center, 85,000 is pretty close. We're spending almost 93,000 per person for in-center hemodialysis. For PD, we spend about 78,000 per person. And interestingly, if you look at renal transplant, that's $37,000, close to CKD 4/5. So, renal transplant is best for the patient. I mean, just from a medical perspective, as well as from a financial perspective as well. So we just mentioned there are 37 million people in the US who have CKD, and there are about 10,000 nephrologists in the US. Unfortunately, it doesn't look like many people want to do nephrology anymore. So that number is actually declining. Works out to be about 3,700 to 4,000 patients per nephrologist, and that's not feasible. So the community as such, the internal medicine internists need to get involved when it comes to taking care of our CKD patients. So what are some of the barriers that primary care physicians face while providing CKD care? This was a study published in the Journal of Renal Care. It's an old study, 2012. But some of the points that they listed after interviewing patients and providers were patients' low awareness and poor recognition of CKD, because of course it's asymptomatic until later stages. So, it's never on the patient's agenda. They want to take care of the acute issues. And then primary care physicians view CKD sometimes as not as a distinct medical problem. If you look at coding, It's type 2 diabetes with complication of diabetic kidney disease. That's how it is coded. The perceived complexity, again, it's from a patient and from physician perspective, both. Kidney disease is complex. And then the fear of dialysis, that's it never goes, but it's worse when you start discussing it with patients, and it sometimes overwhelms them. So most primary physicians, they don't feel comfortable engaging in that discussion at all. Then, of course, time constraints for primary physicians as well as for nephrologists, that always exists, and lack of educational resources, dietitians, that is another problem. So when it comes to awareness, like we mentioned, early stages of CKD, patients are barely aware that they have CKD. It's only when they go to a physician and their labs are checked that they find out they have chronic kidney disease. Of course, when it comes to stage 5, later stages, they start developing symptoms, and most of them would be aware. But early stages, there's a lot of unaware people. Now, this is an interesting, again, USRDS data slide that it's people with CKD, even CKD5, the 1-year cumulative probability of visiting their cardiologist is higher than their nephrologist. And of course, primary care is higher. So I know many of you here are budding cardiologists. If you see that happening, please send them back to me. But this is I found it very interesting that they still don't want to see the nephrologist, even in advanced CKD. So from a primary care perspective now, we have tried to distill CKD care down to some practical, high impact, evidence-based principles that are easy to go through in the visit. The KDIGO guidelines are our nephrology guidelines, which are, huge. They are extremely, lengthy and overbearing, to be honest. And their level of evidence is not that great. When we talk about phosphate, MBD management, anemia management, the level of evidence is not that high. But regardless, then we have the ACP guidelines, which just has 4 points, screen for proteinuria, start ACE or ARBs, lipid management, and another one, which I'm forgetting, but it's just very basic guidelines. Unfortunately, both of these guidelines are really old, from 2012. The KDIGO is coming up with new one starting 2020, and it's still, it's coming up with those guidelines as we speak. But still, we don't have anything great available at the moment. So from your perspective, when you're in the office, we're not talking about hospital here, because we don't necessarily see CKD, it's AKI in the hospital. But when you are in your clinic or office, who needs screening? So the evidence that everybody needs to be screened for CKD is generally poor. We need to do targeted testing for CKD in high-risk populations. Now, many of us, if you look at these conditions, that's almost 90% of our patients. Anybody with diabetes, hypertension, obesity, age greater than 60, family history of kidney disease, certain race groups like African Americans, Hispanics, and Pacific Islanders are more susceptible to CKD, as we know. And APOL1 gene, I don't know who does genetic studies in the office, but if you have that data, of course, they are at higher risk, especially if they have 2 alleles. So coming to the definition of CKD, it's a very, CKD is a complex definition. It is not just your GFR. So it's defined as abnormal kidney structure or function, lasting more than 3 months with associated health implications. So each of these words are actually important, structure or function. If you have just one kidney, even though you may have a creatinine of 0.5, you still have CKD. The kidney impairment, the functional impairment, needs to last at least 3 months to call it CKD. Before that, it's AKI or AKD, acute kidney disease. So staging of CKD, when we talk about CKD, it's not enough to just, say their GFR and say they have CKD. You need the GFR, you need albuminuria, the etiology of chronic kidney disease, and of course, chronicity, more than 3 months. So this is your CKD heat map, which I'm sure many of you have already seen. It looks very complicated, but we just spoke about it, that, on your y-axis is your GFR. We're not going to go through each category, but it goes from 1 to 5 based on just the GFR. And on the x-axis, on this side is your albuminuria. Now, just to remind you, it's albuminuria, it's not proteinuria. So albuminuria, A1, A2, A3. Anything over 300 is severe albuminuria. And the color coding here is your risk of progression of CKD. So the darker the zone they are in, the higher the risk of progression. And these numbers I'm going to talk about it in a little bit, but this just says the number of visits they should have to check their kidney function and overall well-being if they have that stage of kidney disease. So CKD G4, A3 need to be seen at least 4 times and have labs done at least 4 times in the year. So talking about GFR, that's our number 1 on the CKD list. Now we used to consider GFR as the best way to measure kidney function, and we routinely use it to assess progression of CKD. Now the difference is between measured and estimated GFR. Measured is what we have learned in our probably in your med school you learned how you do inulin clearance or iohexol or 24-hour creatinine clearance, which honestly nobody does in this day and age. So what we are left with is estimated GFR, and our best marker so far that we had was serum creatinine. Now the problem with serum creatinine that we are coming up with is that we have these complicated formulae or calculations to calculate eGFR. They're as complicated as it gets, if you can see. From 1976, then we changed to MDRD in 1999, and the most recent one was CKD epi in 2009. And then starting last year or so, we noticed, or we started, this was an ongoing problem, but we just came up with it, unfortunately, that we are using race in these clinical algorithms, and race is a social construct. It's what the patient tells you. It's not really skin color that we can depend on. And can you really, go by what the patient is mentioning in their chart, or can you go by skin color? Probably not. So now, there was a huge uproar, you guys already know, and then ASN and NKF convened a national task force to use race in GFR, and now we're back to square one, where after 50 years of all these complicated equations, we're back to 0. We don't know what to do. So what happens with current eGFR equations that use race is that they actually disadvantage Black patients. Their GFR, so the hypothesis is that Black patients have higher muscle mass, and creatinine comes from your muscle. So that coefficient that they add for the Black race, it gives a higher estimate for the GFR as compared to a non-Black person. So now when it comes to drug dosing, it depends on the GFR. Transplant weight, that's really important. If somebody's GFR is 32 versus, or you can say 25 versus 18, the 18 is able to be listed for transplant, but anybody with over 20 is not listed for transplant. So that's a little difference in GFR makes a huge difference in their life. And then CKD referrals at the right time, dialysis initiation at the right time. All these are just based on GFR, which is actually just a number. And we have given these categories of CKD, just based on this one number. Now you go down from 30 to 29, you've gone down from CKD stage 3 to 4. But in all honesty, it's a continuum. So I don't know if we should really depend on that one number to decide so many major issues here. So there are positives and negatives to this GFR estimation if you underestimate versus overestimate. Like we mentioned, drug therapies are based on GFR, the dosing, and we start avoiding drugs if patients' GFRs are low. For example, metformins, fluozins, or especially chemotherapy drugs. That's so important, but patients are not given chemo sometimes based on their GFR. Contrast imaging, you have seen so many patients who need MRI with gadolinium, but they couldn't get it because their GFR was 29 instead of 31. And then it leads to unnecessary anxiety. When you overdiagnose, it can lead to unnecessary anxiety with CKD, unnecessary referrals, unnecessary access planning, surgery to get vascular access. So it's a big deal, really, when it comes to just this one number. So now we were trying to, as a nephrology group or as a society, we are trying to move a little bit away from creatinine. And cystatin C has been available for like a long time. It's another biomarker that is, it's a protein secreted by cells, and it's freely filtered. There is no tubular secretion, unlike creatinine. So GFR estimation equations that use cystatin C do not need any racial coefficient, because remember, the assumption was muscle mass, but here it's coming from all cells. So you really don't need any kind of a racial coefficient here. But the problem with cystatin C is that it's not available in all labs, number one. Number two, it's expensive. And number three, it's not been studied that well across all populations. So what we are doing is, you can measure cystatin C. It's available, and we sometimes do it for in LabCorp, and it shows up on Epic. And we can calculate eGFR based on cystatin C and creatinine both. There are equations for that. And if you have a concern that somebody based on creatinine, their eGFR is showing up to be, let's say, between 45 to 59, and they don't have any other markers of kidney damage, so then you could use one of these equations and see if they actually fit into a kidney disease, CKD spectrum, or if their GFR is actually higher than what it was from the creatinine equation. People have now, most recently, this is from the CRIC study, where they looked at creatinine versus cystatin C. So the upper panel is creatinine, the lower is cystatin C, and the darker line is Black race, and the lighter one is non-Black patients. And any deviation from this dotted line shows that there is a bias in estimation of GFR. So when they used creatinine with just age and sex and without race, there was a definite, bias. So it's not a good equation to use, honestly. If you take out race from that CKD EPI 2009 or 2021 equation, it's not the best way to estimate GFR. They also looked at self-reported race, and that actually fit in better with no race when they looked at creatinine. And this is when they looked at genetic markers for African ancestry that fit in better as well. When it comes to cystatin, although, you see that it does not matter, all the lines kind of coincide, so the race doesn't matter here. So what we are left with is, right now, I don't have an answer for you, like what we need to do, but we are moving towards, right now, what we are doing is we have moved to CKD EPI 2021, where we have taken out the race coefficient from the creatinine-based eGFR equation. Now, I just showed you in the previous slide, it's not the best way to estimate, but that is the best we have at the moment. Hopefully, we'll start using cystatin C more commonly, and we'll come up with better markers. Now, the other important thing to remember is that the change in creatinine is not linear to changes in GFR. Let's say your creatinine goes up from 1 when your GFR was 100 to 2, your GFR goes down by 50%. Whereas if it goes down from 6 to 8, your GFR barely changes. So that's important to remember when you see patients, that it's not a change in points is not the same. So now, leaving the GFR and going to the next part of your CKD is proteinuria. And it's rightly said, when learning about kidney, GFR gets all the glory. Proteinuria is barely talked about, but the deeper you go down the rabbit hole of CKD, the more important proteinuria becomes. We know how protein is handled by the kidney. It's the glomerular barrier and the tubular barrier. And when they're overwhelmed, you get proteinuria. And albumin is your major protein in the urine. So what happens when you have proteinuria? These are your pre-CKD tubular cells. Once you start seeing proteinuria, there is interstitial inflammation, release of cytokines and chemokines that damage those tubular cells and cause cell loss, tubular atrophy, and eventually there is scar formation, or what we call interstitial fibrosis. And once that happens, the remaining nephrons start compensating and they become hypertrophied. So when we do a kidney biopsy, actually IFTA, or interstitial fibrosis tubular atrophy, that's the term IFTA, the percentage of IFTA they see in the biopsy is the most important marker of how that patient is going to do, regardless of the cause of their AKI or regardless of what management you're going to pursue. If they have a high degree of IFTA, you may use whatever you want, but it's irreversible. So that, you know, this is a very important part of CKD, that this the fibrosis is irreversible. In terms, when we talk about proteinuria, there are several ways of measuring protein. So one is urine albumin creatinine ratio. The second one is urine protein creatinine ratio. Then sometimes we just do urinalysis with 1+, 2+, or 3+ protein. And the last one is 24-hour urine protein. So urinalysis, I mean, it's extremely easy. Patients can even do it at home. It's highly sensitive for proteinuria, and it's very cheap. However, it's semi-quantitative, so you don't get much information from that. When we talk about actual measurements of proteinuria, if you do UPCR, that measurement is not standardized across institutions. And it uses a chemical assay, which is good. It's cheap, but it's not a standardized measurement. The 24-hour urine collections we no longer do, because there is such a high chance of inadequate collection, inconvenience, and there is no diagnostic advantage provided, because the same information you can just get with the ratios. So albuminuria is what we generally tend to use for following proteinuria, and that's measured by standard ELISA tests. And the morning sample is the best way to measure proteinuria, UACR on the first morning sample. If you have patients coming in the office, that's the best way to check it. You may ask now, how, if you have UPCR, can you calculate UACR from that? That doesn't happen. You can't do that. There are no real calculations available. We do know now, you do know about this, that, we said albumin is the major protein in the urine. However, in conditions like myeloma or dysproteinemias, you see other proteins forming the overwhelming, being the overwhelming cause of proteinuria in these cases. Just to give you an idea that, like I said, there are no calculations or conversions for UPCR to UACR, but approximately this is how it looks. So if you have 2+ protein on the dipstick and you have greater than 500 UPCR, you probably have severe albuminuria of greater than 300. Now, we've always focused on GFR as a risk factor, as a cardiovascular risk factor. However, albuminuria is actually an independent risk factor for cardiovascular events as well. This was a study done in the Netherlands. It was a prospective, large study, long follow-up, 10 years. And they looked at MACE events, cardiovascular events, and found that, they looked at eGFR, albuminuria, and traditional cardiovascular risk factors, and found that albuminuria was a distinct risk factor for cardiovascular events. So how are we doing when we talk about urine protein testing? So, for our at-risk population, which we know will develop or may develop CKD, just 50% of them get proteinuria testing done yearly, which is not good. So we are doing almost 94. This is the VA, it's from a VA study. And when it comes to eGFR screening, 94% of patients got screened. However, when it comes to albuminuria or proteinuria, just 56%. So I think we need to do better in that regard. Now, the third aspect of CKD is your cause of chronic kidney disease. And, many a times, you would see it in the renal notes as well, probable. Probable is a word we use a lot because we don't do renal biopsies unless and until we feel like it's going to change management and you will get an appropriate diagnosis. I'll talk about kidney biopsy in the next slide, but as you can see, diabetes and high blood pressure is the majority of cause of CKD. A high blood pressure is kind of a difficult thing here because what happens is you can't say what came first, chicken or the egg. Did high blood pressure occur because of CKD, or did CKD happen because of high blood pressure? That's difficult to say, but hypertensive nephrosclerosis is still classified as a cause of CKD. Glomerular disease, not a big percentage, just 7%, and 1.6% is polycystic kidney disease. This huge other is the unknown. Many a times these patients will come to us with a creatinine of 5 or 6, and they don't have diabetes or high blood pressure, and we just no proteinuria, nothing. So they just get lumped into other. Maybe they had contrast, or they had some AKI. We just don't know, ATN, AIN, so many other reasons that can progress to CKD from AKI. So when we talk about kidney biopsy to diagnose CKD, you must have seen we rarely do it. It's not something we do routinely. If we can identify a cause of CKD without a biopsy, with just serology, or patient already has diabetes and proteinuria, we don't tend to do a kidney biopsy. It's only done if it's really going to change your management. And a pretest probability is very important here. If you have no idea what you're biopsying a patient for, the likelihood is you're probably going to find some IFTA and some tubular damage here and there, but nothing that will change your management as such. Some of the reasons why we would do a kidney biopsy, again, this is not all inclusive list. There are many other reasons, but for CKD, if there is unexplained nephrotic syndrome, and there's a whole talk on nephrotic syndrome, but when we call unexplained, that means we can't find a reason based on blood tests or serology. So membranous, sometimes you can have PLA2R negative membranous GN, or FSGS, minimal change disease, amyloidosis, especially secondary amyloidosis. If a patient has acute nephritis or RPGN, where you see RBCs in the urine, RBC CAS, high blood pressure, rapidly rising creatinine, then of course that's an indication for biopsy. Unexplained AKI, then again, it's a black box. I mean, it depends. It's on a case-by-case basis. If you think that there is reason to biopsy and you're gonna change the management, let's say it's a drug-induced AIN and you want to start steroids, then you need a kidney biopsy. But otherwise, if you're just gonna wait and watch, there is no reason to do a kidney biopsy. We don't do a kidney biopsy for just isolated hematuria, because again, you're not gonna do anything about it. The most common reason for isolated hematuria would be IgA nephropathy or C3GN, or thin basement membrane nephropathy, which we really don't treat. And then subnephrotic proteinuria, the management is not going to change. You're going to give them ACE and ARBs. So that does not make any difference here. When do you guys refer to nephrology? I mean, you've been doing it. You don't need this list, but when it comes to CKD, anybody with CKD 4 or 5 needs to be referred to nephrology for future planning. At high degree of albuminuria, greater than 300, or if it's a rapidly progressing CKD, which we say in more than 5 milliliters per year decline in GFR. Other reasons, if you see red cell CAS or refractory hypertension, electrolyte abnormalities, nephrolithiasis, hereditary kidney disease, all of these. So just to show you that heat map again, the red zone, you definitely want to refer to nephrology for future planning. What we do for CKD patients in the office, some of you have been in the office, these are all the things that we focus on. There's a lot, we cannot cover it in one talk, but mostly hypertension, volume status, anemia, metabolic bone disease, acidosis. Medications, very important. We look at medications, anything nephrotoxic, dose you need to adjust, glycemic control, and prevent any AKIs that may be happening. So from a medicine perspective, what you can do for patients is, number one is primary prevention for your high-risk patients, which we mentioned in a previous slide. You identify those patients, and again, it's primary prevention like you would do for them anyways, manage their obesity, glycemic and blood pressure control, avoid high salt diet, healthy lifestyle in general, and no nephrotoxic medications. And then if, let's say, they develop CKD, and then the next step is to kind of slow down the progression. So that is called secondary prevention. And there we're going to talk about what we can do to slow that down. But that would again be some medications, better BP control, and avoiding AKI and diet. Tertiary prevention is where we come in. Patients is developing progressive CKD, and now you need to manage the consequences of that, which we just mentioned in the previous slide. And then once they, go past that, it's then, talking about renal replacement therapy or conservative management. Renal replacement therapy consists of either dialysis, kidney transplantation. They may choose to just do conservative renal management or palliative care. So when it comes to slowing the progression of CKD, we talked about risk factor mitigation. Then we want to reduce the proteinuria and related inflammation and fibrosis. And renin-angiotensin-aldosterone system by itself, the activation of this system causes damage. We want to take care of the metabolic acidosis as well. So just one slide about blood pressure. I know the AHA guidelines, the latest one, state blood pressure of 130/80 as their goal. Nephrologists want to go a step ahead. And so KDIGO recommends for anybody with CKD and high blood pressure, the recommendation is 120/80. And ACE and ARBs are the first line medications for these patients, especially if they have albuminuria. So just a word about glomerular hypertension. What happens is that when you have CKD, or few of the nephrons are not working and others are being overworked, there is an activation of angiotensin 2 associated vasoconstriction of the efferent arteriole, just because we want to increase the glomerular pressure, intraglomerular pressure, to cause more filtrate and increase the EGFR. However, that process is counterproductive. What happens is that when there is vasoconstriction, yes, the EGFR increases. I mean, you can imagine there is increased pressure and there is increased EGFR, but it also causes further worsening of proteinuria because protein gets filtered, and that is a cause of damage. So what ACE inhibitors or ARBs do is that they, this is your constricted efferent arteriole in a damaged glomerulus. What they do is they kind of dilate that efferent arteriole and decrease the intraglomerular pressure. So that decreases your proteinuria. It's just pressure, it's just chemistry, you can say. So it decreases the pressure across the membrane, and there is decreased filtration of protein and decreased proteinuria. However, your EGFR also decreases initially. So that's why, if you remember, you have learned that, ACE and ARBs may cause some decrease in GFR when you initially start it. So what we recommend is once you start ACE or ARBs, you monitor the creatinine and potassium very closely. And if there is normal kalemia, you want to maximize the ACE or ARB dose to maximally tolerate it. If there is hyperkalemia, don't give up just then. Review their other medications, consider dietary intervention, add diuretics if you're able to, add sodium bicarbonate for acidosis. And if nothing else works, we have patients on Lokelma or binders to kind of keep them on the ACE and ARBs. However, if you notice a more than 30% increase in creatinine from these ACE and ARBs, then you need to review again all of these medications and any other cause of AKI, and you may want to scale back if their creatinine continues to go up. So the next one, I mean, you guys are probably all Schlossenators by now. I kind of love their logo. They even have this apple tree here because the initial compound was isolated from an apple tree bark. So that's the newest, most exciting thing happening in nephrology, I guess, is SGLT2 inhibition. And we still don't know the real reason how it really helps your kidneys, to be honest. But we do know that it causes glucosuria and natriuresis. So, you pee out salt and sugar. I mean, that's the best that can happen to you. You're peeing out the sugar. So you have negative caloric balance. You have better A1Cs. you have decreased inflammation and, better cardiac and renal protection from that. And natriuresis, or, you just kind of put out the salt that you're eating, that the patient is eating, that decreases their blood pressure, that decreases their intraglomerular hypertension and overall volume correction. So that again helps in your cardiac and renal protection. This is just a basic slide. I mean, there are deeper, and we're looking into it deeper, to be honest, as to how SGLT2 inhibitors affect the kidneys. So we have known about SGLT2 inhibitors for maybe more than a century, to be honest. And initially they were being developed as diabetic medications. But then during the studies that were being done for diabetic medication, when they were doing those studies, they noticed that there were better outcomes in terms of cardiac outcomes were better. So then they specifically did studies to look at cardiac outcomes with SGLT2 inhibitors, and then they noted some renal improvement as well. And then we started with all this, all these studies that are now bombarding us, and we know that they all have show a positive outcome. Credence, which was the initial one in terms of kidneys, and they just included diabetics and patients with proteinuria and diabetes. Then the DAPA CKD went a step further, and it included patients with or without diabetes, and the GFR cutoff was lower to 25 from 30. And now the latest one, EMPA kidney, that is still we don't have the results yet. It's awaited in 2022. That has gone down further to eGFR 20 and patients with or without diabetes. So we are eagerly awaiting the results of that study. Interestingly, the DAPA CKD had patients without diabetes, 30%. I'll show you in the next slide. They had 30% patients, just 67% had diabetes, 30% had proteinuria without diabetes, and many of them were actually had IgA nephropathy. So our IgA nephropathy studies are not that big as some of these, SGLT2 inhibitor studies. And of course, we see a positive outcome with that. I'm not going to go into details. You've probably all gone through these studies. So when it comes to management of diabetes in CKD, our guidelines and also the ADA guidelines recommend, comprehensive care, ACE inhibitor, dietary changes, individualized A1C targets, lifestyle interventions. And then when it comes to anti-hyperglycemic therapies, metformin and SGLT2 are number one now. If a patient has a GFR of less than 30, we don't like to give SGLT2 inhibitors. That is changing slowly, as I just mentioned in the last slide. So our next target, remember the RAS system is renin-angiotensin-aldosterone system. So the last target here is aldosterone. And that also causes inflammation, it causes sodium and water retention, inflammation, fibrosis as well. So one study that came out at the end of last year was your Fidelio DKD study that looked at finerenone, which is an aldosterone inhibitor. It's a mineralocorticoid receptor inhibitor. And the best part about it is that it is highly selective. It is non-steroidal, unlike spironolactone. Just give me 1 second. Okay, sorry about that. So, okay. So the difference between spironolactone, eplerenone, and finerenone is that the other two were steroidal, and this is a non-steroidal compound. So you don't see gynecomastia and other, issues associated with the other two. It is highly potent, and its tissue distribution is both kidneys and heart. So finerenone, again, it was a huge study, 5,600 patients with diabetes. After they added ACE and ARBs, they added ACE or ARBs, they added finerenone as well, 10 or 20 milligram daily dose. And what they saw was that there was, in patients with CKD and type 2 diabetes, it resulted in lower CKD progression and lower risk of cardiovascular events. So again, both cardio and renal protection from this. Of course, as you can imagine, when you have MRA, mineralocorticoid receptor antagonist, you're going to have high potassium. When they looked at the mean potassiums, there wasn't much difference actually in the placebo and the finerenone group. However, when you looked at their safety outcomes, yes, there was significant hyperkalemia, 11.8% versus 4.8%. Now, hyperkalemia to the degree that it required permanent discontinuation was not that high though, 2.3 versus 0.9%. These patients were already on ACE or ARBs. So that is another exciting, medication or intervention coming up for prevention or protection of kidneys. So we talked about the RAS inhibition. We have done studies to look at combination of these things. When we looked at renin inhibitor and ACE or ARBs, a combination of that, the altitude study, that was a failure, and there was significant hyperkalemia in the patients. So that was not recommended anymore. You do not use renin inhibitors with ACE and ARBs. Similarly, when they tried to do both ACE and ARBs together, the VA nephron study, again, severe hyperkalemia, it was a failure. The study was actually stopped. And we don't recommend using ACE and ARBs together. But this Fidelio DKD, the latest one, again, there was some hyperkalemia, but I think it is not to that degree. So we are looking at adding finerenone to ACE or ARB. So that would be a new thing. It's like a combination of drugs to maximally protect from the RAS activation. Last thing I have is metabolic acidosis in CKD. Now, it's metabolic acidosis is a consequence of CKD, right? You typically see it when you have low GFRs, less than 40 typically. And it happens because the acid load coming from your diet is unable to be excreted. And this is a non-anion gap metabolic acidosis. You usually don't see AGMA until the CKD is very advanced. And that happens when patients start retaining other acids like phosphate, sulfate, urate, and hippurate. But early stages, you would mostly see NAGMA. So the consequences of metabolic acidosis, bone resorption, increased catabolism of muscles, insulin resistance, and it adds on to systemic inflammation and progression of CKD. We don't have great studies to look at, if correcting that acidosis improves the renal function, but smaller randomized controlled trials and mostly observational studies have shown that, that it may improve or it may delay CKD progression. So the KDIGO guidelines recommend maintaining sodium bicarbonate concentration in the normal range, 23 to 29. We now have, when a patient comes to you, you can actually pull up some of these risk factor equations to kind of tell them what their future looks like in terms of, are they going to reach dialysis in 10 years, 5 years, or they may not progress further. So these are kind of very useful because everybody with, let's say, a creatinine of 2 is not the same, right? Somebody may progress faster, somebody may not progress. This is something interesting that our, the Mount Sinai, not our division, but the Mount Sinai, the east side, the researchers there have developed a tool called Intel X, Kidney Intel X. They look at biomarkers other than your usual creatinine and cystatin C. They're looking at other biomarkers. And they also include a clinical history in their equation derived from the EHR, and they give you a prognosis based on that. So that's kind of interesting that we are, looking at other biomarkers now other than creatinine And the last thing I want to just mention is something called renalism, which we all practice all the time without realizing. It's the underutilization of diagnostic and therapeutic interventions in patients with kidney disease out of concern that they are more likely to do harm in this patient group. So we are trying, we're doing our best, and for that reason, we don't sometimes give them certain medications or use contrast or do procedures like cardiac caths just because we worry about their kidneys, and that's renalism. Fortunately, we are trying to move away from that, as you saw with SGLT2 inhibitors, and now with gadolinium use, we are using it in advanced CKD and even contrast use. So that's where I will end. And if you guys have any questions, I will take that.
Thank you, Dr. Batwara. Does anyone have any questions? You can either unmute yourself or post in the chat. Okay.
Okay, you can email me if you have any questions, and thank you very much.